Here to start the panel discussion. The topic is very simple: bronchoscopy in TB. Can we invite our panelists on stage? Kamlesh. Yes, yeah. Laptop on. Thanks.
हाथ धोया तक हाथ पैसा आ जाएगा.
So I would like to invite Dr Rajneesh Gupta, Dr Sidhharth Raj, Dr Sudershan Pothal and Dr VG Vinod on the dais.
So till the time they are coming to the stage, inviting them on the stage help. So we all know that panel is still very boring. So we try to have some twist in it. The theme of the discussion is based on IPL. So the thing is, we all know that cricket is now booming a lot. IPL is going on. So we thought that let's have something interesting, make it more interactive with the help of some cricket. Now we have to select our team. So we are in Delhi. So capital Delhi. We know that we have Sansad, Rajya Sabha, Lok Sabha, everything over here. So now, obviously, our team has to Delhi Capitals. So Broncocon Delhi Capitals also our team is. So now the whole panel, we can say we have two bowlers and these are the batsmen. We can say so. We are making them practice so that they can win the matches for us. Okay. So me and my colleague Dr Kamlesh are going to ball some kind of different balls over to them, normal googlies, rapid fires, whatever you can say, and we start the discussion that way. So starting with the ball rolling, the routine balls, we can say one of the bowler for Delhi Capitals is Mukesh Kumar. So we'll start the first question. Dr. Sudershan, can you just let us know what are the diagnostic and therapeutic indications for doing a bronchoscopy in TB patients?
Thank you, sir, for the question. First of all, basically, we do the bronchoscope for age-regard tuberculosis, which comes mainly diagnostic. It could be through hydroptic bronchoscopy or REG bronchoscopy. For the purpose of diagnostic, mainly we are interested to take the sample. Say for example, we are suspect clinically or radiologically tuberculosis. In that case, we want to take some bowel or bronchial was or arrangement so and so. Simultaneously, age regard to the therapeutic in concern, we are used to do more rather rigid. It could be due to the severe say hemorrhage, say disease, or could be due to some say intravascular stenosis or obstruction. Or it could be due to some treatment, particularly some fistula, bronchial fistula, fistula, and so on. These are all indicated both hydroptic as well as already.
Kamlesh, next ball from your side.
So next question to Dr Rajneesh. What are the contraindications for doing bronchoscopy in a TB suspect patient?
Thank you, sir. Basically, the contraindication, if the patient is not giving any written consent, that is absolute contraindication. We have to have.
Very nice point, sir. What is very important.
Then, if he has got severe refractory hypoxemia, the patient having bilateral symptom disease, is on ventilator, and if the PO2, if the saturation is not maintaining 90% or more on, say, FiO2 more than 60%, so we should not take off a hospital. Then cardiac arrhythmia, patient hemodynamic landscape, so we should avoid doing bronchoscopy. Then there are certain related contraindications like if it's uncooperative, or the recent MI, or uncontrolled hypertension, or respiratory failure. So we should also have, we should try to avoid those. Is that contraindication?
Local one, if there's no space going inside, tumor mass, something there, or bleeding, very severe, then definitely we also avoid it. Definitely. Next question for Sidhharth. So, where do you see the conventional bronchoscopy nowadays in the diagnosis of mediastinal lymphomas?
So thank you. And you are wearing the color of Team India. So I'm taking that ball. So the thing is that conventional bronchoscopy in diagnosis of mediastinal tubercular lymphadenopathy. So what happens these days? Usually what happens is the patient who enters in our OPD, many of times they come with a lot of CT scans. And we all know that these days The adenopathy, without any parenchymal lesions, may be tubercular. But we need to differentiate that whether it is tuberculosis, sarcoidosis, lymphoma, cancer, we have to differentiate it. So in that case, now with the emerging role of EBUS, which is readily present in our city in Delhi, but if we look at the Indian scenario, the tier 1, tier 2 cities where actually the India resides, we don't have all these things. So there is still a role of conventional bronchoscopy and conventional TBNA. But the thing is that the right patient should be chosen, that the node should be big enough, the usual site should be station 7 and 4R, which are the ones which can be easily assessed. And I would say it's a thing which the cost cutting can be done, if it is done in an experienced hand. That's the thing. So I still think there's a lot of role of conventional bronchoscopy and TBNA can be done where EBUS is not available.
Definitely. Is everyone can afford a Mercedes Benz?
Yes.
So normal cars are also has to be done. That's true.
So one point I would like to add.
Yeah,
The same thing, one particular patient was referred for bronchoscopy wash who had diffuse nodules, but there was a 2 centimeter node. So where the node sampling eventually turned out to be malignancy and not being sampled, so I would encourage all the people to note, to specifically sample the node, even if conventional conventional TBNA still has to, but we definitely have to think about sampling the node.
One point I would like to add up here, it's very important to look at this area. If the depth of the node is not too much, we can easily go by the conventional angles.
Dr. Vinod has already warmed up, and I would ask him the role of rigid bronchoscopy in suspected TB patient and how did he manage the case of post-TB bronchial stenosis?
This particular scenario we see little rare because we tend to do regular flexible scopies. Rigid scopy comes specifically to a point where we are anticipating some high-risk patient, like it's bronchostenosis that happens very commonly. And I would, in this category, one thing is we should have pre-procedure sequence planning. We tend to do, we won't know because many times the stenosis happens to be very narrow. And bronchial stenosis, we don't know what is on the other side. We should not end up doing complication. Perforation of the. So any patient who comes, most of the time the role of rigid scopy for the first question is towards the stenotic lesions commonly, or in a condition where there is a massive hemoptysis or doing a flexible procedure, you ended up having a catastrophe there. Rigid backing will be beneficial. But if such patient comes, CT, and then we tend to reconstruct the CT virtually to know what is beyond the stenosis. And is it safe to dilate, and dilation also can be done in sequential parts, not to be over enthusiastic, causing a perforation complication. So I would see, plan, and then in this after dilatation also, when we do a bulk dilation, is the role for stenting or not? Again, that depends on the place where they are trained. In my center where I trained, the producer doesn't encourage doing a stent. He says TB, don't stent, something like that. But there are cases that the case series and experience from other centers say you can do it, and once you achieve a stability, you can get the stent out. So ultimately, you are the decider. And when you are able to achieve an adequate lumen, then probably you can have a close follow-up, see if the patient needs further dilatation or stenting.
Sure, I said. So next, we saw that they played all the balls very well. So now some kind of off spin has to be coming to the picture. So we introduce one more bowler. So Rajneesh, Dr. Rajneesh, you want to know that have you managed a case of sputum positive cavitated pulmonary tuberculosis with moderate hemoptysis?
Okay, thank you very much. So, TB patient having cavitated lesion and having moderate hemoptysis. First of all, we should provide the immediate supportive medical. So, it should be made to put in a running position with lightly breathing lung to be on the different side to prevent aspiration to the opposite lung. Then we should maintain oxygen supplementation and ventilation. Then hemostatic should be given, antitussive, anxiolytics, etc. They should be given. We should put IV line, etc. Then we should try to localize the site of bleed. So bronchoscopy is helpful,
we can exactly know which segment of the lobe bleed is coming from. If it is not, it doesn't help, then we can go into a rigid bronchoscopy or CTM. Then we have therapeutic interventions we can do via bronchoscope. So codes and lavage can be easily instilled. That will cause vasoconstriction. Then we can put topical adrenaline. Then we can use hemostatics again topically. And then ablative techniques can be used like electrocautery, which can seal the vessels. Then your argon plasma coagulation is there. So the Fogarty balloon can be used to tamponate breathing vessels. And recently, like oxidized regenerative cellulose is also used to and then bronchial artery embolization and surgery.
Other extreme measures, but yeah, definitely can be used.
So, next question to Dr. Sudershan. What are the bronchoscopic findings usually you see in endobronchial tuberculosis?
Right. Basically, endobronchial tuberculosis. So before I go to the finding, classically, whenever we are telling the endobronchial tuberculosis, it's either histologically or microbiologically has to be confirmed. There are 7 types of description explained. Say, for example, one is non-specific bronchitis type. Second is acute KJT type, active KJT type. Third is say stenosis type, ulcerative type, granular type, and tumorous type. There are around 7 types are discussed. But most, out of all, the most commonest is chronic non-specific bronchitis type and some kind of granular type and so and so.
Definitely, sir. So that endobronchial TB is always a misnomer. We don't know from outside when you go inside and we know that TB is inside. So basically, it's very helpful. Bronchoscopy definitely helpful, sir. So now, Dr. Sidhharth, you want to know that what are the anticipated complications when you go inside and doing bronchoscopy for a TB patient, sir?
So the anticipated complications of patient when you're doing a bronchoscopy for a TB patient, suspected TB patient are 2 types. One is the patient-related complications, other is the healthcare worker-related complications. Right. So it's the similar like all the other complications. It's basically hypoxia can occur in the patient, pneumothorax while taking TB, LB can occur, then bleeding can occur, post bronchoscopy fever can occur. So these are the things, and bronchospasms, laryngospasms are the ones. The other important thing is the healthcare related, because we all know that doing bronchoscopy in a patient of tuberculosis leads to aerosol generation. So wearing of personal protective kits is very important in those scenarios, and that can lead to distribution infection in healthcare workers. So these are the basic complications.
And some anesthesia related complication also. We are not expert in that, but they do occur. Yeah.
So next question to Dr. Vinod. Chest X-ray suspected of TB, but patient refuses bronchoscopy. What are the various things? How do you approach next?
There's no consent, as was said. No consent. What to do?
So this I commonly encounter because we have 2 sides of work in our hospital, corporate side and medical college. So medical college, eventually patient comes and our bronchoscopy is only 3,000, which also some patient will be very anxious to do and not affordable. So in that scenario, we try to do the man to a site TB test. And sample wise, if you want to get out sputum, we encourage them to do some normal tidal breathing technique, and we encourage them to take some water. These are conservative things which we tell them, and again rethink whether the patient has given a proper morning sample which is required, and then we give recommended thing. One commonly studied agent is hypertonic saline, and in one patient, I had witnessed hypertonic saline nebulization itself caused patient bronchospasm, even had to be admitted in ICU. So that has changed the practice in the hospital, and from then on there should be a crash cart, and there should be dedicated center has been come up. So we need a proper center, proper staff, and backup complication prevention. Other than this, we can use normal saline, we can use mannitol, other agent expectorants that can be tried. But we were going through literature, even a stool sample has been tried and tested for pulmonary tuberculosis, African countries, I think they have. So in ICUs we tend to take gastric lavage, which has to be overnight NPO, and then feeds has to be stopped, and morning 6 o'clock we take it.
And chest physiotherapy also many times helps for patients. So basically, exercise induced food. That's true, sir. So now basically we go to Dr. Sudershan again. So any specific bronchoscope disinfection methods, because we know that infection is definitely there to next patient. So what to do for it?
Yes, it's very much important because actually if you are following the standard protocol, it's okay. But still, we have to take into concern what we are using is a disinfectant, particularly supercritical radii. It has to be kept at least 20 minutes. That's important. Second thing is after say washing the bronchoscope, ideally it should be kept 70% alcohol. That is the two important things, particularly as regard to bronchoscopic. But usually by standard protocol we are following that. But still it has to be more strict.
Right. Definitely. But you don't infect the patient. That's what generally what things are. So now coming to, because they have played very well, so we feel that we need to give some other kind of walling symptoms, walling techniques to them, because they have played a off spin also, they have played a normal ball also. So now, yeah, Kamlesh, go ahead with the next question.
Should we do a bronchoscopy in a patient with normal chest X-ray, and we know that sputum is gene expert positive? Any scenario in which you will consider doing bronchoscopy in such a patient?
We all very well know that always, like, it's not the dictum that every tubercular patient should have some lesions in his chest X-ray. Many of times our normal chest X-ray patients also turn out to be sputum positive, and gene expert positive has got very high specificity. So in such a scenario, when patient, we should look at the clinical condition of the patient. What is the symptoms patient is having? If patient is having symptoms of like cough more than 14 days, weight loss, fever, along with that gene expert is positive, I would not recommend doing a bronchoscopy. But in other scenarios, sometimes patients are adamant that we want to get it repeated, so my chest X-ray is normal. At certain conditions, we can get the gene expert repeated at times. If it comes out to be positive for the second time also, then no if and but we have to give the ATP. But at times it is negative. In that scenario, we go for a CT, and if we find lesions on CT, then definitely we should go for a bronchoscopy. So that is my take on it. Others can add to it.
One thing I want to add in this context. And suppose clinically we are suspecting some local image, that means clinically suspect some form of intraventricular growth might be there. That could be the cause of this sputum positive of clinical. We can do that.
The one googly was inside, but we had not mentioned CT scan. So you can ask for CT scan first, and then can decide. So basically, bronchoscopy, CT, X-ray, CT scan, and then bronchoscopy. So that was going to help us telling the clinical picture over here. So Dr. Sudershan, basically again a question for you. In a patient where generally in a corporate hospital we have suits, suit means bronchoscopy suits, multiple scopies are done for the patient. One of a patient, we didn't think that he will come positive for TB, but has become means gene expert trace positive. So what is the first thing to do?
See, very good question, sir. There are two aspects it is. In regard to patient perspective, means the patient goes getting positive gene expert, but it is a trace. By dictum, if it is a trace we are clinically not suspecting, means we need to repeat the test.
Right, sir.
Repeat the test, either any form, either we can use another vial like that, or any other evidence of either CBNet or LPA, so and so. But in other, in regard to other perspective, means suppose say bronchoscope is exposed to the tuberculosis bacillus. It could be the first that means we need to think of that is probably distinct contaminant by severe specific. That's why we think to see that whether our say protocol, classical protocol of sterilization, that part also is covered. Third part is suppose multiple scope is available. I think we can dedicate it to one scope for tuberculosis.
Yeah, that should be the, if you have options available for your institute, definitely that. And one more thing, you can just give a call to a previous person who done the scopy. भाई तेरा patient positive था क्या? So just getting the idea that if it is positive and yours also come positive, might be a disinfection not done properly. You can go ahead. That's true.
And we tend to keep as last patients.
Yeah.
Generally, we tend to keep which is expected.
Generally, to the last. That's what the problem is. Yeah, Kamlesh.
So next question to Dr. Rajneesh. What are the precautions for doctors and staff for doing a bronchoscopy in a TB patient?
Okay, so before this, so we should have a bronchoscopic place where there should be infection control measures should be in place. So preferably there should be 15 air change per hour. Then there should be exhaust system with unidirectional flow. Then negative pressure design should be there. Then UV HEPA system should be there. Then UV GI system, that is for decontamination upper area of the room, that should be there. And there should not be any recirculation of it. Right, so that automatically decreases the contamination to doctors and staff. Of course, they have to observe standard precautions like the kits, then the N95, face shield, eye shield. Also, people are using disposable gloves.
Right.
So that again is
I have a full stop. That was important.
One thing I noticed is like till we finish, everyone is concerned.
Yeah.
Once the procedure is done, everyone removes the mask and they just roam around the same place. So that
Nice observation. That's true. You know, remember that the bugs are still there in the same environment. Go out and then remove the mask. Perfect. So, Dr. Vinod, the question is to you only. So, when would you consider doing a diagnostic bronchoscopy in an MDR TB patient who is already on treatment regimen?
Recently I had encountered a patient where his diagnosis was sputum positive and MDR TB in a background of silicosis. So in that patient there was no other risk factors for any chance of MDR TB. So again the thinking was whether it's really a valid sampling technique, is there an error in the sample. So we went ahead and did a bronchoscopy, lavage, and it turned out to be gene expert sensitive. So we rechanged the diagnosis and we pending the samples, further samples like LPA and other things, we made it again drug sensitive TB regimen. That's the first thing. Like if there is a suspicion, if it's not MDR, that's reconfirming the diagnosis. Second, during monitoring, the patient is not able to bring out sputum samples. So that time probably to consider whether the
3 months sample is not available.
So then final thing is at the end of treatment. So if there is persistent radiological infiltrates, where is the doubt between inflammatory post TB sequelae and residual disease.
Or TB is not cured.
Yes. So that's one consideration. Very odd consideration is not in MDR TB, but in many patients with the drug sensitive TB. I had encountered at least 3-4 patients of ABPA along with TB, where we want to introduce steroids. Co-infection, coexisting diseases.
The thing is, the patient is on treatment and worsening of the symptoms or worsening of X-rays, and basically sputum is not available or something. That also we can think of doing a scope.
And if you are contemplating surgeries, surgeons may ask for scope.
Definitely, they will want to know that the things is clear. Definitely. Yeah, Kamlesh. Now, basically, they have gone through all those googlies and things. Now we will be quick on them. Like Mr. Start is coming to play. So quick questions for each of them. Let's start with the first one.
Yeah, so Dr. Vinod, while doing the scopy, you see an exfoliative growth. What would you do next?
Yes, so this has changed over the time. In last 10 years, when I was learning any growth or anything, we try to jump at it. So now, after encountering few patients, we try to, when we are not planned, the first thing is obviously any growth or any malignancy suspicion or any mass lesion, we need to plan. We had, I'll just give a scenario, we had a patient, we went in, we encountered a large left main bronchus tumor. We were enthusiastic, we took out even flexible scope with local anesthesia. We took out, but we ended up having the tumor fallen on the other side. So where the patient had residual tumor in the left main bronchus and a complete block in the right, we somehow took out. By the time the patient arrested, there was anesthetist, code blue was given and then intubated, is required on the table. So any growth, obviously we need to be sure that we are enough planning is there. We need a CT, we need an understanding what's the extent of the disease and how vascular it is. And do we have all the tools to go in and retrieve it safely?
A simple thing is nowadays is CT and virtual bronchoscopy also helpful. But if you see the growth, always think of biopsy first and sending in the proper place so that the measure done properly. Yeah. Next question to Dr. Sidhharth. What type of OT flow arrangement generally needed for doing a bronchoscopy? For this all questions about TB suspects.
Actually, for this question, I think my runner has
Already
answered it. So
the what is still remaining?
but still, I take it to the client
There are
for
one
that.
answer.
So the thing is that it's the same thing. Dedicated should be there. And the thing is that we are preaching it, but we don't practice it. The thing is that in our setups. So it should be a negatively pressurized suit should be there. The air exchange rate should be 12 to 15. A HEPA filter should be in place. These are the things which are very necessary.
Lamellar flow. That's what I'm saying. Definitely. Yeah, Kamlesh.
So next question to Dr. Sudershan. What are the different bronchoscopic techniques used for diagnosis?
Yes, classically what we used to do at bronchoalveolar lavage, bronchial valves, evosticating for the needing to do, even radial pro biopsy.
Very good. TB and classical, both the things, conventional and Dr. Rajneesh, can you enumerate the various tests which you send across for the bowel samples?
So normally in a TB patient, we also need to look for the co-existing infections.
Right.
So TLC, DLC, whether it's acute infection or chronic infection, then we will send samples of biologic samples, bacterial isolation, then fungal smear culture. Of course, TB, we will be sending out Jaden smears, CB and molecular techniques, then midget smear culture. Then your automatically to go for, if it's positive, then LPA, then your viral test for viral isolation, then maybe there is rarely that may still malignancy, so we look like cytology for instance. Then other special tests can be there, we can look for if hemorrhage suspected and leukocyte macrophages, etc.
Case wise, this is for TB patient.
On clinical suspicion, we can take it.
Definitely. Thank you so much. Next, we are coming to the end of this show. So basically, it's a super over for all of you. So basically, it's kind of a small ending remarks from each one of you. So starting with Sidhharth from your side, we can end from.
My remark would be that yes, if we have all those bronchoscope with us, TBUS with us, this gives us great power, but we should use them very responsibly. That comes a big responsibility. We should only do cases which actually require these things.
Right.
We shouldn't just run for number of cases. We should understand when to do, what to do, select the right patient. So that is what I
am going to put in endoscope. No, that's good. Nice one.
So bronchoscopy can be safely done in a TB patient, and provided we take certain precautions, we select our patient properly, rule out contraindications, and BAL is a useful test which can provide doctor information.
Because tuberculosis is endemic in our country, so we should not forget the basic things, means sputum, true net or CBNet. This is the first. Because if you are identified through sputum, no need of doing much more diagnosis regard to diagnosis is concerned. Yes, some sort of therapeutic we are concerned, particularly there is some sort of stenosis is concerned. But basic thing before doing bronchoscopy, sputum or true net or CBNet is the most important.
In my experience, bronchoscopy in TB humbled me in 3 occasions, 2-3 occasions. Like scopy samples being negative, again gastric acid turned out to be positive. CSF samples negative, again CT didn't show much, and then bronchoscopy eventually, after debating with ICU team, we ended up on the losing side. We said against TB, finally it came out to be. So it humbles, and we have to always keep.
Remember that work enters the lungs first. So basically, if you go there, site you might get positive. Definitely, well, good point taken. Kamlesh, some point for one.
So on your IPS team, I would like to say is play spinners confidently. So be confident with your procedures. Googly ball pe prevent your own wicket. So use your safety precautions well.
Definitely. So yesterday I was speaking, Dr. Vivek sir is not around. So basically he wanted Modi ji to come to the conference. So I tried to have a small video which basically gets the Modi ji walking with us, and definitely we can have to the conference. Towards the ending remark that I always remember there is a film called Chha in which that warrior had many weapons with him to fight against. So that is always we have the weapons, various techniques available for the bronchoscopy, but you have to use with precaution, which to use when to get the proper heal outcome. That's what I mean. Thank you all panelists for your humble suggestions. Thank you so much.